afternoon and welcome to the Health Gorilla Jungle. Thank you for joining us under our canopy for today's webinar, Navigating the QHIN Jungle, How to Choose the Right Path. We are excited to share our insights on navigating the nationwide interoperability ecosystem to help you make the best choice regarding when, how, and where to connect. Let's take care of some housekeeping before we jump in. I'm Abigail Blythe-Batten, and I will serve as your moderator throughout the webinar. This webinar will last 45 minutes, and we promise we will respect your time. You can ask questions throughout by submitting them in writing, and then I'll offer the questions at the end to our experts. Now let's meet those experts. Dr. Stephen Lane is Health Gorilla's Chief Medical Officer. Let's start with you. Will you provide our audience with a brief introduction?
Happy to, Abigail, and thanks so much. Thank you, everyone, for attending today. I'm a practicing primary care physician and clinical informaticist with over 35 years experience using and advancing health information technology. The past 20 years, I've been focusing on health information exchange and the advancement of nationwide interoperability networks and frameworks. I have helped to lead and govern a number of these HIT frameworks and initiatives over the past few years. I was honored to serve for 6 years on the Federal Health IT Advisory Committee, where we did a lot of work advancing TEFCA and getting us set up for the current moment. I have served as Chief Medical Officer here at Health Gorilla for the past 3 years, and I represent our network participants on the TEFCA Governing Council, other work groups through that, as well as multiple other national and regional interoperability initiatives.
Okay, that leaves Derek Plansky, our SVP, Architecture and Strategic Governance. Take a few moments to introduce yourself to our audience.
Hi, folks. Yeah, I'm Derek. Nice to meet you again. Thank you for joining. I've been around the interoperability world since about 2008. I'm originally an aerospace engineer, so when someone says, it's not rocket science, I can comment officially on that. But at some point, I can explain how I got into healthcare, but I've been doing it for quite a while. Really focused on the interoperability side, working with a number of different HIEs, both from the vendor side as well as being on the working within communities and so forth to exchange data, and have seen a lot of different use cases. And my primary responsibility at Health Gorilla now is between solutioning and the governance and the compliance piece associated with TEFCA and all of our other national networks. And currently I am on the TEFCA QHIN caucus, representing Health Gorilla and all of our participants in that space. So happy to be here.
Excellent. Thank you both. You can see, audience, that you're in capable, intelligent hands throughout this webinar. So what do you think? Should we jump in like proper gorillas? Let's jump. There has been much discussion about TEFCA's future. Derek, can you speak to the concerns that some have expressed that TEFCA is dead?
Certainly. I think this was more of an issue towards the beginning of the year during the transition of the administration. There was some uncertainty. Who was going to be heading up ASTP. There were a lot of concerns about, cost cutting and efficiency in DOGE and so forth. And I think there were some naysayers who have, not necessarily been the most pro TEFCA, who were using that as an opportune time. But at this point, I don't think it's dead. It's growing like crazy. And I think we have 3 sort of major data points to assert to that. First of all, it's the level of activity that's going on the governance side, both from ATSP and the RCE. Secondly, we have growing participation in interest from our communities and other people asking more and more questions about it. And lastly, by virtue of the fact that we're connected to all the other QHINs, we see the traffic and it's growing like a hockey stick. It's definitely up and to the right, like the early days of some of the other national networks as well. So we see a bright future in TEFCA.
Okay, that's a comprehensive answer, Derek. Thank you. Dr. Lane, I feel certain you can deepen this discussion from your perspective as a clinician and speaking from your colleagues. Is there a risk of waiting to partner with a QHIN and to begin to engage in exchange via TEFCA?
I think, during the very early year of the first year of TEFCA, I can understand why some colleagues, providers, were hesitant to join yet another framework when there were established frameworks that were meeting their needs. But we've really seen a shift in that. We've seen providers progressively joining TEFCA, increasingly over the past year or so. All of the major EHR vendors have either selected a partner QHIN like Health Gorilla or are establishing their own QHIN to facilitate TEFCA exchange for their users. The largest categories of exchange today on the framework are for treatment, payment, and healthcare operations, as these were originally defined in TEFCA. And these definitions are being refined. I'm sorry, they were originally defined in HIPAA. Many years ago, more than a decade ago. These definitions are being refined in the context of TEFCA to clarify ambiguities and really to build trust amongst the participants. There has been a concern about trust, and of course, trust is the first word in TEFCA, so that's a big focus. So treatment exchanges, as we know, is well established on the legacy interoperability networks and frameworks that Derek and I have helped to build. Payment and operations today are mostly managed over much more burdensome proprietary and bespoke connections. So the goal, really is to move all of that volume of exchange onto the more efficient, more modern, more trusted exchange framework that TEFCA provides. So as providers and payers in particular migrate to TEFCA, there are going to be increasing challenges to efficiently accessing and exchanging needed data for those who are not on board. So I think now really is the time. It has proven that it's going to have legs and move forward. Those who engage in TEFCA exchange and now, sort of in the early days, also have the opportunity to really get involved and to help define and govern the standard operating procedures as they are rolled out, including participant vetting processes, which is an important part of TEFCA. We actually review every new participant to make sure that they qualify for the exchange purposes that they're purporting. So it's a good time to get involved. Absolutely.
Okay, I think that we silenced that rumor. Probably everyone's on the edge of their seat by now, wanting to keep our promise. We promise to stay within the time limit. We're mindful of that, and that you will walk away with an earned swagger in knowing how to choose a QN. So let's talk about QNs. Before we jump into the soup bowl, Dr. Lane, it would be useful, I think, for the audience if you would provide a brief summation of what is a QN.
Sure. So QHIN is an acronym. Obviously, it stands for Qualified Health Information Network. And the way we architected TEFCA, after the 21st Century Cures Act was passed, all TEFCA exchange is managed through QHINs. So QHINs are the single on-ramp to this framework of nationwide exchange. And it took us a while to sort of figure out just what that was going to look like and to have different entities apply and be reviewed and approved. But the first 5 QHINs were designated in December of 2023, and Health Gorilla was amongst those. We were on stage in DC. It was very exciting. Since then, 5 additional QHINs have been designated, and there's one more that's in what's called candidate status. But I'd be surprised if we ended up with more than a dozen QHINs supporting this framework. And Health Gorilla has been, live since the very beginning. QHINs are designated and managed by the TEFCA Recognized Coordinating Entity, or RCE. So you'll hear that acronym. And that is done in collaboration with the Office of the Assistant Secretary for Technology Policy within the Department of Health and Human Services. So another acronym is ASTP, previously known as ONC, the Office of the National Coordinator for Health IT. So lots of acronyms here. The governance of QHIN policies and exchange is managed by the QHINs and their participants and sub-participants in collaboration with the RCE and ASTP. And as Derek and I mentioned, we're both involved in that governance, as are perhaps some of you who are watching today, and certainly a number of Health Gorilla's participants and network participants are doing that.
Okay, thank you for that overview. So it's time to talk about the challenges in choosing a QN. We're going to put our rocket scientist on hold for a little bit longer, Derek, and we're going to go to Dr. Lane because you're on a roll. Let's start with you. Let's talk about data quality and usability. and how it affects a patient's outcome. Can you expand that thought?
Absolutely. So just as a reminder, I'm old enough that I used to practice medicine on paper. So when you talk about data quality, it was just like, can you read the handwriting, right? Things have changed in the last, 40 years. We're all familiar with the adage, garbage in and garbage out, right? So exchange participants, they were making decisions based on complete and accurate information that's presented in a format that allows the relevant data to be integrated into established workflows, are simply able to make better decisions. They'll be able to create greater value for individuals, organizations, populations, you name it. So having access to comprehensive, high quality data is key. There's an increasing awareness of the challenges of data quality within healthcare in particular, and the usability of data. So the quality has a lot of definitions, but usability sort of incorporates the quality of the data itself. And there are a number of efforts underway today to define, evaluate, and improve the quality of the data that's being exchanged. As we move into the age of AI in healthcare, we know that those algorithms really they're dependent on data. And again, if you give poor or incomplete data to an algorithm, it's going to give you a poor or incomplete or inaccurate answer. So Health Gorilla has long been committed to the deduplication and normalization of the data exchanged on the network. And as new standards for data quality and data usability are defined, we are at the table very much involved in driving and implementing those standards. And we anticipate that those will also be incorporated into TEFCA and other required exchange programs.
Okay, thank you, Dr. Lane. Derek, I feel confident you have something important to say here. Tell us just how different are the governance structures of the different QHINs, and do these differences even matter?
So, since this is about picking a QHIN, governance is one of those key aspects that has an intangible aspect around it, but ultimately it's around maintaining the trust through efficient processes for the overall compliance. So there's a certain floor that all the QHINs have to meet. So naturally, arguably, all of them are trustworthy, and we are very collaborative amongst each other. But there are some nuances and differences. So some of the organizations themselves, I would say the two legacy networks that have become QHINs, eHealth Exchange and Commonwealth, they probably have the longest history around governance. But I would say what's probably more relevant these days is breadth, in the sense of breadth of different use cases, in the fact that there are a number of treatment purposes, a number of exchange purposes. Treatment is one of them, individual access is another, payment and operations are others. And so ultimately, you really want an organization that is familiar with the different exchange purposes, and they're not just trying to stick to just one or two, perhaps, or perhaps having proprietary networks out of the back that are doing some subset of them, so that they're not as incented to do the exchange purposes. I think also fundamentally, it boils down to, again, the breadth and variety of networks. And one of the things that I'll say, naturally pro Health Gorilla, because I'm working here, TEFCA is one network. Health Gorilla manages connections to 5 different network regimes in terms of compliance. So having that breadth of understanding the different networks and the nuances and slight differences between them is very useful and very important to help navigate, because as QHINs are rolling out, there's still not 100% coverage on QHIN, so you really do still need to have a strategy to talk to some of the existing networks, such as Care Equality and Commonwealth and eHealth Exchange on their legacy platforms.
Okay, so the differences do matter. Thank you. It's the lightning round. We're going to explain how to choose, explaining how to choose the wrong QHIN. So this is our lightning round. This is going to be good fun. Derek, please name a couple of ways you know if you've chosen the wrong QHIN. Go.
That you don't, well, the time it takes to implement and also the clarity with which they're able to describe how to onboard into TEFCA for the various different use cases. That's certainly two areas of concern. The other one is the breadth of offerings so you're future proof. Those are sort of the three areas that I would look for in general.
Okay, well done. You kept in our lightning round speed. Dr. Lane, you're up. Can you provide some quick examples to show how connectivity and reach are vital to a thriving QN from a clinical perspective? Go.
Absolutely. Yeah. And I'm not going to be maybe quite as fast as Derek, but as a clinician, you want to be able to access and utilize all the relevant information that's needed to support clinical and business operations and other decision making. So when you're missing data, you're inevitably going to be making suboptimal decisions. And there's real impacts of this. The first one, is the risk to patient safety and to patient care. If you're not recognizing a drug allergy or a drug interaction that might be documented somewhere, if you redo an imaging study that involves ionizing radiation, you've got a patient unnecessarily exposed to that radiation, and delaying treatment because you don't know the full story of what is needed. So patient safety, I think is the biggest concern. And then wasted resources. Not having access to all the data that you need leads to duplicative testing. It may lead to unnecessary outreach to populations in order to close care gaps. Incomplete quality reporting is incredibly important. In the organization where I practice, the access to comprehensive external data allows us to have accurate quality metrics, and we get way better reimbursement because of that. So, I mean, one of the real challenges with not having access to the best data, not having the best partner, is you don't know what you don't know. So it's critical to partner with a QHIN that can provide access to as much data as possible in a format where that data can really be utilized.
If
Okay.
I can pile on
Yeah,
just
Derek, jump in, please.
one other thing related to that, and there's the situation where you may not have complete data, but there's also the other end of the spectrum where you may have too much data. And having the ability to process and deduplicate the information, from hundreds of clinical documents and summarizing that into
or thousands,
narrow scope for thousands, exactly. Reduces the cognitive burden on providers and clinicians who are reviewing the data, so that they're less likely to miss something or just get burned out from having to review a surfeit of information. So.
Yeah, that's a good addition. Stephen, did you want to talk a little bit, Dr. Lane, do you want to talk a little bit about network breadth and why it matters?
Yeah, I mean, I said earlier about why having access to all, having access to all the data or as much data as possible is really the goal. Now, Health Gorilla, and one of the reasons why Derek and I are here, has been at this for a long time, over a decade, and was an early participant in basically all of the major national health data networks and frameworks that preceded TEFCA. I mean, TEFCA is not a new idea. TEFCA is built on and by the folks who've been doing this work for a long time. Health Gorilla is now, along with the other QHINs, also committed to serve as an aligned network within the CMS interoperability framework, which is complementary to TEFCA, and they're being managed collaboratively by the folks at HHS. In addition, and this is unique, Health Gorilla is the only QHIN that also serves within the California Data Exchange Framework, which is called the DXF. In California, they refer to QHIOs, Qualified Health Information Organizations. So Health Gorilla is dual designated as both a QHIN and a QHIO. This provides increased access to data and certain types of data like ADT messages within California, which is, if you're doing business or seeing patients who ever find themselves in California, is pretty important. So I think, it's fair to say that Health Gorilla can access as much data as any other network, and probably more than many.
Okay, thank you. Here comes the good news about QNs. We can now see how dark a not so great QN can be. Derek, take us back to the light. what about data quality? How can we even measure something like that?
So, as Dr. Lane was explaining some of the challenges with data quality, there are ways to mitigate some of those concerns. And unfortunately, data quality is one of those nebulous terms. It's like, the blind men and the elephant, they have different views of it based on where they happen to be situated around, the trunk or the tail or the feet. So data quality means different things to different folks. Like there's an aspect of data usability, there's an aspect of data completeness, there's an aspect of data correctness, and there's an aspect of data plausibility. This is the classic example of, a female receiving a prostate exam, or, a male receiving a hysterectomy, or, certain things that are just improbable. You can only amputate the same leg, one time. So those are different dimensions that can be used to measure data quality. There hasn't been a unified description or agreed upon definition of what data quality was. A lot of people just defined it what was convenient to what they were working on. There has now been a bit of a coalescing around a standard called PICI, PIQI, and I'm remiss that I don't remember what it's called, what it spells out specifically. But it was a technology that one vendor had, a clinical architecture that they had been promoting and actually have given to the community as a framework to use for data quality. In fact, it's being adopted in HL7 as a standard. So it isn't vendor lock-in. Obviously, it had an origin in a company that has a great reputation in terms of assessing data quality, measuring it, and understanding the different dimensions. And we're seeing as part of the CMS aligned network that there's some growing momentum behind this notion of having a standardized way for us to measure this quality. So we're looking forward and believe that the PICI is the future for at least a certain set of data quality measurements, and specifically around what CMS is going to be looking for going forward. So, I'm excited about the future there because there's an actual framework that people can align behind. That's
Yeah,
So
all.
that's
just to add to that, Derek, so PICI stands for Patient Information Quality Improvement. And Charlie Harp, who's the founder and CEO of Clinical Architecture, and I sat down over a napkin and actually sketched out that framework together, or pieces of it, because there's a real focus on how complete is the data with regard to standards like the U.S. core data for interoperability. So yeah, I agree with you. That is sort of finally something that we can all look to. The other thing is that within the Sequoia project, we've been working for many years, even back before Sequoia took it over, on data usability. So there's a Sequoia data usability work group that has now issued 2 different implementation guides for the usability of data. And I think those are really the 2 benchmarks that we're looking to nationally, the PICI and the Sequoia data usability, as how we drive forward with regard to data quality.
okay. Well, it sounds like there's a lot of machinations going about data quality, but let's talk about raw data. Dr. Lane, you're the top doctor in the health gorilla jungle. Tell us, or tell our audience, why raw data isn't enough for a practitioner.
Yeah, so I mean, early on, 20 years ago when we started doing data exchange, you would take anything you could get. It was better than having nothing at all. Early data exchange was built on what's called HL7 V2 or version 2 data feeds that are set up, between two entities. So there's standards for that. And then came the continuity of care document, or the clinical document architecture. But the CCD, or continuity of care document, is also managed by HL7. But it has proven to be very challenging for clinicians who need to quickly access relevant data in their workflows. You get these sometimes huge documents you have to pour through. They're variably formatted based on the data source. So deduplicating and normalizing the incoming data, whether it's coming as a V2 feed or a CCD or something else, is incredibly important to making that data available for use by humans or by AI. In both cases, you really need to have the data working. And one of the best ways to format that data is to use the Fast Healthcare Interoperability Resources, or FHIR standard, which Health Gorilla has used since its inception. And that allows the data to be integrated into local systems and workflows, and allows that data to be turned into useful information and then actionable insights, which of course is critical in the age of AI. So
Okay.
raw data just ain't enough.
No, it's not. All right,
So,
Derek, you want to bring us? Oh, Derek, did you want to add something to
well,
that?
yeah, I was just going to add one other thing associated with that. So raw data, even if it is extracted and put into the FHIR format, which is much easier to work with than the previous generations, there's also an opportunity for enrichment and correction as well, where there may be things like missing codes or blank fields or ambulatory encounters where they have a start date but no end date. And we all know ambulatory encounters can't last more than a day by definition. So there are all sorts of inferences and value adds that can be added on top of the data if you have a platform that is doing the granular extraction and manipulation of the data. So the data quality measurement is the first step, but then once you identify those gaps, a lot of them can be remediated. And of course, it's very important to make sure that those remediations are clearly listed as new information, because you obviously always want to have the original source information or raw data that you can go back to. So you have that provenance chain. But just wanted to say, beyond raw data, you want to have enriched data because it brings you more value and it's less data processing for you if somebody is taking care of a portion of that for you.
Okay, thank you for adding that. We have one final question in the lightning round, Derek. It's for you. And you've touched on some of this, but maybe expand in areas. It's something we haven't touched on yet. Some divergent points among the QHINs.
So the main divergent point between the QHINs of whether or not they are pass-through or whether or not they do some aggregation and processing. Pass-through is certainly simpler, it's easier technically, but you're then just limited by what information is being surfaced from the originating sources, which right now, the majority of which is purely documents, which gets back to that data overload problem that I was talking about before. Whereas the QHINs that do aggregation can reduce that burden for you and do some of the improvements, the deduplication, the standardization, the collection of all of that information so that you have less information to sift through. That's the biggest distinction. One of the other ones I'd like to say is, you want to pick someone who has their own technology stack. Certainly as a company that was born out of Silicon Valley, we're very tech forward. And we think that that gives you flexibility and also responsiveness versus having to wait for, say, vendor solutions to update. So those are the two main ways I differentiate them.
Okay, that was sharp. Thank you. Very exciting. We just ended the lightning round. So we're going to shift focus here with the caveat of saying this webinar is informational. This is meant to be educational and useful, pragmatic. But Health Gorilla does have some special features, and we maybe could use our Health Gorilla as a model QHIN. So thinking about that as a background, Derek, maybe name some features about Health Gorilla that demonstrate how QHIN's health and value to the participants, maybe from a technical angle.
Sure. Well, some of that goes back to one of the differentiators of, aggregating the data. And so clearly Health Gorilla is in that camp.
Yes.
And we process and deduplicate it. I think also it's not, although this talk is about TEFCA, and TEFCA is growing like a hockey stick, but it's growing from zero, which it started in December of 23. So it's been almost 2 years. And there are millions of transactions, but it's still not at the same level of the other networks. So having access to multiple networks, I think, is an important aspect as well, not just being, siloed into one particular QHIN. So those would be some of the main advantages. Again, it's a good collaborative environment that the other folks are we're friendly, but we obviously want to compete and differentiate ourselves. So I think the data enrichment and the data processing and having it centralized is one of the primary differentiators for Health Gorilla. and that we also support other use cases. We have a number of other workflows that are outside of TEFCA, like lab ordering and receiving ADT alerts and so forth. So just the breadth of offerings, I think, are very compelling, in my opinion. Obviously, I'm biased, but
Well, you should be a champion of the company that you
right,
represent.
absolutely.
Yeah. Okay, so I know that Health Gorilla normalizes and deduplicates data. Dr. Lane, can you explain why or how that matters from a clinician's point of view? You use EHRs as part of your practice and regularly access external data. So you might have some insight here.
Oh, absolutely. Yeah. So I do see patients, and care for them all the time. And literally every patient that I see, I am challenged by the opportunity to reconcile outside data. Um, and bringing that data into the local record is exponentially more difficult, if not impossible, if that data has not been deduplicated before reconciliation. I mean, if for many of the patients that I see, they've received care in half a dozen or more different institutions over the past couple of decades where digital information is available. And if you get every version of the same drug that's been prescribed, you're just never gonna reconcile it. In order to integrate that external data, such as medications, such as laboratory results, into a local record, that data also has to be structured and coded appropriately so that the system can differentiate whether the potassium information you're receiving is about a pill for potassium or a test result for potassium. And there are innumerable examples of this. So having deduplicated, codified, normalized data is just critical to care. If it's not in the right format, in the right workflow, you're not going to be able to utilize it, even though you may have this huge pile of data sitting behind you. EHRs are increasingly supporting TEFCA Exchange, and their users will benefit from this access, so long as the data that they're getting is clean and codified and well structured, and can be meaningfully integrated into the provider's workflow. But a network like Health Gorilla can access, normalize, enhance, and deliver that data. But it's really up to the EHR or other health IT system to create the end user experience and to bring that data forward. So if you are a clinician or you're using an EHR or other health IT system and they are not receiving this data, they have not connected to TEFCA, now's the time, send them a link to this webinar, and say, they should not only be connecting to a QHIN and getting the data, but also doing the hard work, which it's been proven by multiple vendors that this can be done. We've been doing this for well over a decade now of bringing external data into local workflows. So I think that's critical for clinical benefit.
Okay, thank you, Dr. Lane. You guys have been very liberal with your acronyms, and people love those. So maybe, Derek, you could spend a few minutes explaining how Health Gorilla's FHIR repository affects client experience and how our QHIN supports strategic IAS partnerships.
Yeah, sure. So as I'd mentioned previously, we have a repository, and one of the things that we do is take the incoming data that we've retrieved on behalf of our participants and aggregate and deduplicate it, and then put it into a FHIR repository. And we actually convert it into an internal format first, but that way we can more easily convert to multiple FHIR formats. We currently support STU3 and FHIR-forward. And then once you have that data, again, the benefits of FHIR are that the data is much more granular. So if you're only interested in doing meds, say Dr. Lane is doing a medication reconciliation workflow, you could just retrieve the meds as opposed to having to look across, hundreds or thousands of documents. There are some challenges with the data being too fragmented. So one of the things that Health Gorilla has also been working on is maintaining the linkages back. So incorporating, tying it back to the encounter that the medication or the procedure was associated from. That's not standard functionality in all FHIR servers out there. So, we've done some work to make sure we handle all of those. But that's basically the things that we like to offer up through FHIR. Also, FHIR has this notification capability where you can receive updates if new data has been present, and go from there. But yeah, that's in short the summary.
Okay, thank you. It was a good summary. We have about 10 minutes left, so I want to remind our audience, go ahead and write your questions in, and we'll address those in just a few minutes. But in the meantime, I want to ask Dr. Lane a question about what risks organizations might face by choosing a QN that only provides a conduit for data exchange and doesn't evaluate and optimize the data that flows through it. I know you have some opinions on this.
Yeah, and we've discussed the critical importance
Yes.
of deduplicated normalized data that can be integrated into workflows and analytical tools. This data normalization really requires that the data that's received, whether it's via V2 or CCD or some other format, can be torn apart, decomposed, processed, so that recipients can receive the data that they need in the format that works for them for that integration. So that's critical. Network data analysis and processing also provides the opportunity, as Derek has said, to provide these value-added services. One of those that Derek didn't mention is identifying and managing highly sensitive data in a way that you can be compliant with evolving privacy statutes at both the federal and the state level. That's a very high bar. Something that I've been involved in for a long time. And we have evolving standards there. But again, that really requires you to see what data is passing through your system. Derek mentioned the quality and usability remediations that can be done. But I think that's really important as we look at what your options are for data exchange.
Okay, thank you for that. I'm glad you brought up privacy. That was an important topic. Derek, will you discuss how AI-ready data transforms interoperability's value?
Sure. There's obviously a lot of hype and excitement around artificial intelligence. It's been offered up as the solution to just about every problem known to man. But there are absolutely valuable use cases in healthcare around it, and I think the biggest one is probably clinical summarization. So helping create a relevant and context-specific summary for a provider, so that an ED doc has slightly different interests than, say, a general practitioner or a nephrologist or whomever. And so those are I think the primary use case. But yeah, AI is definitely going to transform healthcare. I think everything from the education to the delivery of the information over time.
Okay, thank you. We're going to move to the question answer portion with just a few minutes left.
Yeah, I
So,
see there are two questions
yeah,
in the
we've got two
Q&A.
questions out.
There are two great questions. I don't
Yes.
mind taking the first one.
Yeah, go ahead, Dr. Lane.
Yeah,
That's perfect.
so Jared asks, for sub-participants, what will be the difference in connecting to TEFCA via an EHR QHIN, such as Epic, versus another vendor QHIN, such as Health Gorilla? And as a clinician, I think that if you're dealing with the exchange of your EHR data, and your EHR offers QHIN connectivity, I'd be hard pressed to argue against taking advantage of that. In the very first iteration of TEFCA, you were only allowed to use one QHIN. But then we fixed that. And we said, no, you can use different QHINs for different health IT systems. So if you're a provider and you've got an EHR and you've got a data analytics platform or a care management platform or something else, you can connect that second platform through another mechanism. And frankly, if that's not a platform that's supported or provided by your EHR vendor, it's probably your EHR vendor probably isn't even able to help connect that data to TEFCA. So I think that there are many situations where having multiple QHIN partners would make sense for these different systems. Derek, I don't know if you want to add to that.
Yeah, there's one nuance I'd add in there. I think that the larger, more mature EHR systems definitely have very compelling workflows, but I know that usability has been a problem in the EHR market for quite a while. And so to help address that, in addition to having the core data, Health Gorilla has a viewer that can plug in that is a very lightweight but very I think good UX UI experience for reviewing large amounts of data and sifting through it, that can be just plugged into an EHR that perhaps doesn't have the bandwidth, or they'd like to focus on something, other workflows, integrating AI, whatever, into their system, and would like to have the interoperability piece just solved for them. So there is a situation where I think there's a case to be made. I think, Dr. Lane, you've worked with Epic for a long time. So, Epic is the gold standard around that. Certainly Meditech and Cerner, Oracle are also, close competitors, I think, to a certain extent. But those ones, I think the other EHRs that are out there have not focused as much on user experience around interoperability. And I think that's something that a QHIN could potentially bring. And it is one of the differentiators we have.
All right, thank you. I think we have time for Peter's question. He's got two questions. Maybe Derek, you could tackle this first one. Are there minimum data set standards that are clear and achievable for participation in a QHIN?
Yes. So basically, we're currently supposed to support USCDI version 1. And in 2026, we're migrating to USCDI version 3. So in terms of the extent of data that must be exchanged, USCDI defines that very clearly. Whether it doesn't matter what protocol you're using, it's all about what data elements are actually exchanged. So aiming for USCDI v3 would be, or maybe even leapfrogging so you get ahead of it, USCDI v4 would make sense. I think, Dr. Lane, they're up to USCDI v6 that's been defined already. So there's certainly a lag for adoption, and there's technical challenges and work to integrate and add new data elements and make sure that they're codified in the appropriate nomenclatures and so forth. But I would aim for USCDI v3 or v4. And use that as your yardstick if you're looking for it. And then
and just Derek, let me add there, for those who are not familiar with the US core data for interoperability, that is the national standard of which data classes and elements and what supporting data standards are required for data exchange. And I've been very involved in the evolution of that. Normally, all the information about USCDI is available on the web, but it's not available right now. But I did put the link to it in the answer to Peter's question, and you're welcome to sort of grab that and save it for later and go back and look at it.
Okay, we have two more questions. I think we have time for one. Peter had a second question, a follow-up, which was, are other semantic interoperability solutions or companies used other than the clinical architecture that you know of? I don't know, either one of you can answer that. I don't know who's the best one, but let's be succinct.
Yes, there are other solutions. There's obviously smaller homegrown solutions where you can have a very targeted effect of a particular data type. But not to advertise other vendors, but there are clinical architecture, intelligent medical objects, health language, which got bought by Wolters Kluwer. There's Apollon as a lightweight solution. There are a host of them out there, but those are the main stalwarts of the industry.
Okay, thank you. We want to thank our panelists for offering insights on how to approach the choice of a QHIN, and a special thanks to our audience for dedicating your time this afternoon. Gorillas love company, so thank you for being ours today. If you were impressed by what you heard from two of our smartest gorillas, visit us at healthgorilla.com for an even deeper understanding. Thank you very much.
Thank you.
Thank you.